Good evening, I'm DK Rossner. Welcome back to the TTT News. Neoadjuvant therapy has come to play an increasingly prominent role in the treatment of breast cancer. Dr. Aurelio Castrellon is a medical oncologist with board certifications in medical oncology, hematology, and internal medicine. And he cares for patients at the Memorial Cancer Institute who are battling various stages of breast cancer. So we say thank you for joining us, Dr. Aurelio, but I want to start off because literally we are two men speaking about breast cancer. So I want you to give us an idea of what led you to that role, or why specialize in fighting breast cancer.
Okay, yes, good afternoon. Thank you very much for the opportunity. I basically started my career in oncology back in 2003, and what led me to choose this field in medicine was the vulnerability of patients with cancer, especially at advanced stages. And I really felt inside that I wanted to help these people, and I wanted to understand more about the behavior of cancer and the treatment so that I could really make an impact in this group of patients that are so often by certain physicians because of the complexity of cancer and the numerous medications that are used and side effects. Some physicians have a tendency to leave everything to the oncologist and ask the oncologist and let the oncologist deal with this. And I wanted to be that person in the team, that person that was in charge and was had the knowledge to treat this specific type of conditions. And at the time was a field that was starting to take off. That's around the time that novel treatments that we call targeted therapies, were starting to come up, and I felt that was a field that was going to develop very rapidly, and it was going to probably change in the next few years, and it actually did indeed occur like that. And it's a field that has come a long way. So that's essentially the reason I chose oncology.
And we want to thank you for making that decision. Now, a field that has come a long way, but there's still a long ways to go. So we want to ask you for some of the statistics as it relates to breast cancer in the area that you serve.
Well, statistics in terms of survival, let's put it that way, because once people are diagnosed, we really want to know if they're going to be able to have a normal life expectancy, having gone through a diagnosis of cancer. And we're going to speak specifically about breast cancer. This doesn't apply to all cancers, but we're talking about breast cancer stages. And we have placed so much emphasis in early diagnosis, specifically because of the reason that the earlier that these tumors are found in the breast, especially if it hasn't spread to the lymphatics, the lymph nodes that are in the vicinity, the higher the chances for patients to become cured to 5, 10, 15 years from the event, not to have any evidence of disease, no evidence of metastasis, for people to be having, normal, healthy lives. So the chances are better the earlier. Tumors that are less than 2 centimeters in size, tumors that are bordering in about 1 centimeter in size with negative lymph nodes, we cure the majority of patients. Once the disease starts taking on the lymphatics and becoming larger in the breast, it means that it has been in the breast tissue for a longer period of time, so it has given it perhaps time to spread to other places, etc. So that's why there's so much emphasis in early diagnosis and detection, because it has an impact on survival.
The early diagnosis, detection. We started off saying that neoadjuvant therapy has become a little more prominent. But at the same time, I want you to give us a definition, please. What is neoadjuvant therapy?
Okay, thank you for that. So neoadjuvant treatments used to be named adjuvant treatments. That's how oncology really started. Adjuvant therapy was the treatment that was given to patients after they had undergone a surgical procedure to remove a tumor from whichever part of the body was affected with the tumor, whether it was a gastric cancer or colon cancer, breast cancer. So we would give patients treatments, mainly chemotherapies, after the surgery to try to eliminate any residual disease that could have spread to other places of the body. We call these micrometastases, metastases that we are unable to identify through imaging. And we knew it worked because people that were recipients of these chemotherapies, when we looked 5, 10 years after the diagnosis, more of them were alive and free of disease if they had received chemotherapy after the surgery. That's why adjuvant chemotherapy became something very established in the treatment of cancer. Now, we started using the same principle of you giving these exact same treatments after surgery. We started giving it to patients before they were operated, while they still had the cancer, in this case, in the breast. Let's say some patient presents with a 3, 4, 5 centimeter tumor in the breast. The patient is trying to get breast conservation, not have the entire breast tissue removed. We would give these courses of chemotherapies before the surgery. And at the time of surgery, most likely these tumors would have decreased in size to become operable. So we would make unoperable tumors operable. And that was the main use initially for these neoadjuvant chemotherapies. With time, we found out that it also had a prognostic implications, because patients that had the best responses were patients that were most likely to remain free of disease. As opposed to patients that had poor responses, these patients had a higher chance of the disease to show up in the years after surgery. So it helped us with prognostic importance. And with time, this prognostic information was useful to develop therapies that could be given after to patients that have residual disease to improve their prognosis. So there were certain treatments that now we are using for those patients that have significant residual disease after the treatment has been given, because there's got to be something in these tumors that is making them become resistant to the treatment. So we are using other treatments later on to try to improve on their outcomes.
But speaking of treatment, though, Dr.
Yes.
Aurelio, speaking of treatment, how is this type of therapy administered? Is it chemotherapy? Is it biological therapies? How do you administer this treatment?
Yes, when we talk about chemotherapies, specifically in the field of breast cancer, we are 100% speaking about chemotherapy. Okay, when we talk about neoadjuvant treatments, it's always chemotherapies, and it's given intravenously. There are no treatments that are really oral. Now, there's other ways and other treatments that are oral, but they're not being used during the neoadjuvant therapy part. This is mainly chemotherapy when it comes to breast cancer, and it will depend on the type of breast cancer. That's when we will choose the appropriate neoadjuvant chemotherapy according to the specific type, because we have regimens that work best in specific types of breast cancer, giving us the best chances of response in that specific type of breast cancer. So we have many different neoadjuvant chemotherapy regimens.
Now, I want to speak about traditional or adjuvant versus neoadjuvant traditions and practices when we return. So you're getting gear for that. We are speaking with Dr. Aurelio Castrellon about neoadjuvant therapy. We speak about it a little more with him when we return. Stay with us. Welcome back. We are speaking with Dr. Aurelio Castrellon about neoadjuvant therapy as for the treatment of breast cancer. But Dr. Castrellon, in your experience, what are the biggest differences between traditional oncology practice and neoadjuvant therapy in treating breast cancer?
Well, the traditional practices, I think, it depends on the center where we go. It probably depends also in how much research there is going on. I'm not saying that adjuvant therapy, operating first, given the treatment after, there's really nothing wrong with that. But like I said, the advantages of neoadjuvant chemotherapy will be for certain cases where we are trying to do breast conservation. We are trying to obtain information in terms of prognosis as patients that respond to the treatment. Once we leave this treatment in the breast, we have the opportunity of seeing the in vivo effect of the treatment how we can follow this tumor with ultrasound, for example, see if it's shrinking. At the time of surgery, patients have their surgery and the breast tissue could be evaluated to see the amount of residual disease. Those patients that have the least amount of residual disease tend to do better than those that have poor responses, which it's also possible. And perhaps this group of patients that have poor responses, what we're doing today is that we're trying to improve their prognosis by giving them additional treatments. If we were to operate first, Gregory, right?
DK.
If we were to operate first, then we will not know if our treatment was effective or not, because we wouldn't be able to assess the effect as if the tumor is left in the breast and the patient undergoes chemotherapy before surgery.
And that brings me to the point, though. That brings me to the point, Dr. Aurelio. Having one practice versus another, there's some people who feel as they reach to the doctor, they want to have something like the doctor would prescribe a mastectomy. How important to you is the palliative aspect? Because I was reading up some of the things that you were talking about, and you say that it is very important to you to make the patients feel comfortable, making patients feel like persons that you hear what they are saying to you. And does neoadjuvant therapy help with this line of reasoning, with this ethos, with this energy?
No, not really. This is a treatment that is basically given to decrease the possibility of metastasis as well. Remember that we're giving these chemos to make tumors operable and to know how good the treatment works, but ultimately what we're trying to achieve is eliminate any cell that might have migrated out of the breast and metastasized to an organ. I think you're asking about mastectomy versus breast conservation. And yes, there is an important aspect for a woman that will lose her breast and, unfortunately have to live with a scar on her chest if reconstruction is not done immediately, versus a woman that we are able to shrink the tumor and the patient is able to conserve the breast where only part of the breast is removed. The quality of life, of course, of the patient that chooses breast conservation would be better, right? Emotionally, in many aspects. I think that's what you were asking me, correct?
Yes, I was, thank you. But with that in mind, though, what are some of the deciding factors in terms of saying, okay, well, we are going to use neoadjuvant therapy?
Yes, the candidate for neoadjuvant chemotherapy is a patient with a specific type of cancer. Not all of the tumors we need to give neoadjuvant chemotherapy. So tumors that are highly, that has high grade, these are tumors that grow fast. These are the tumors that are if you remember your biology, mitosis is going on quickly, they're dividing. So these are the tumors that will respond best to the effect of the chemo, because the chemo is more active at the time that the cell is in division. And so certain rapidly growing tumors, there's tumors that will grow in a month, they double in size. And patients will tell you, I just felt this little thing here a month ago, and now they have a 5 centimeters. So a mass on the breast. So these are the tumors that are the ideal ones for this type of chemo, rapidly growing tumors, aggressive types of cancers. These are the ones that we prefer to give all the chemo first. That also gives us an opportunity to eliminate certain lymph nodes that might be infected from the tumor, so that by the time that the patient has surgery, less lymph nodes need to be removed from the axilla. That also has an impact in reducing the possibility of swelling of the arm. You see some women that are operated from breast cancer, you see them wearing these sleeves that cover their arm. It's because they're trying to prevent lymphedema, which is a complication that can happen when you remove many lymph nodes from under the arm. And one of the observations that we have had with neoadjuvant chemotherapy is that we have decreased the incidence of lymphedema, because less patients have to have axillary node dissections when they are given neoadjuvant chemotherapy. It also has an advantage in the fact that you finish all your treatment, then you only worry about surgery, recovering from surgery, and other things. Sometimes when people are operated first, there's infections, there's healing time, etc., and we might need to delay sometimes the the chemo that's needed. So giving it up front and then just worrying about surgical healing and other things is an advantage of, as well as of neoadjuvant chemotherapy.
Now, I know you said that you like to try to remain on the cutting edge of the technology, of the research going into this field. I'm wondering how the pandemic has impacted that sort of research. How easy is it to do clinical trials at this point in time?
Well, I tell you, it has actually helped us a little because, clinical trials take time. Patients have to have tests, etc. And at the time where we had the pandemic, that the hospital was really only open to patients that had acute processes, newly diagnosed cancer that really needed to be here. We were able to do research quite successfully because we had all the services available. People could be able to go get their things in more expedited. So I don't think the pandemic really impacted us too much in terms of trials for people that were in need of starting treatment. It did impact the patients coming to see us, maybe because they're out of fear. Some patients didn't want to get certain things checked until the virus situation was better controlled, for example. So we started seeing definitely patients coming with more advanced disease because it had not been addressed during February, March. I started seeing patients that came in August, July, and things that they were trying to get in before. But once they were here, our research was able to be performed surprisingly without much problems. We were able to stay very active in clinical trials during the pandemic.
Okay, now we have about 2 minutes more, but I'm wondering, is there anything that your research has shown in terms of trends or common groups that you can pull together about persons who still present residual diseases after this type of treatment?
Yes, our experience has shown us if we use the right regimen, if we are aggressive enough, we are getting the highest numbers of complete pathologic responses. Complete pathologic responses meaning that we are taking our patients to surgery and no tumor is being identified at the time of surgery. With certain treatments, we are seeing high of those cases, higher every time. And then we have been able to understand better which are the patients that need additional treatment by evaluating their residual disease and administering therapies that could help them improve their outcome. And I think personally speaking, I've been doing this for many years, and my observation has been seeing that I see less women relapsing and coming back with distant metastases these days that I did when we were, starting my oncology training back in 2003. So I think we have definitely gotten better with the treatments and understanding the disease better, and therefore we have been able to help more patients overcome this serious condition over time. And you mentioned immunotherapies. I think that's going to be actually the future of oncology. Expanding on the use of immunotherapies. We have a proof of principle. We know that certain individuals are greatly benefiting. Now we have to find maybe other immunotherapies that help us, benefit other patients, and hopefully also make it available, accessible to other countries, because we have something that's called financial toxicity in oncology, and it's the fact that all of these therapies are extremely expensive.
And definitely that is a great point, although a somber one for us to end our conversation on. We want to thank you very much, Dr. Aurelio Castrellon, for being a part of this conversation. And on behalf of the entire news team, thank you for joining us. Have a good night.